This presentation is to review congestive heart failure in the over 65-year-old population, presented by Lisa Johnson, registered nurse. The objectives of this presentation are to identify pathological changes within CHF patients, to identify non-modifiable and modifiable pathological factors, to identify primary, secondary, and tertiary rehabilitation services, to explore care plan options for CHF patients, to review the role of technology, to identify palliative care appropriateness for CHF patients, as well as review the nurse roles in patient care. The cardiovascular system is responsible for the delivery of oxygen and nutrients to cells, the removal of waste products, as well as the transportation of hormones. Circulation is divided into either pulmonary or systemic. In pulmonary circulation, the waste product carbon dioxide is exchanged for oxygen in the lungs. In the systemic circulation system, blood carries oxygen and nutrients to cells and waste products to the kidneys, liver, and skin for excretion. For homeostasis to occur, a properly functioning heart is needed to propel the blood through three types of vessels, which include the arteries, capillaries, and veins. The lymphatic system assists in maintaining homeostasis by returning excess fluid from the body's tissues back to the circulatory system. Blood low in oxygen and high in carbon dioxide enters the right side of the heart from the systemic circulation through the superior vena cava and the inferior vena cava, which empty directly into the right atrium. The right atrium pumps the blood through the tricuspid valve to the right ventricle. The right ventricle pumps the blood to the pulmonary arteries. The pulmonary arteries then carry the blood to the lungs for reoxygenation. The pulmonary veins return the newly oxygenated blood to the left atrium. Blood pumps from the left atrium through the mitral valve to the left ventricle. The left ventricle pumps blood through the aortic valve to the aorta. Blood is then transported to the body, beginning with the coronary arteries and the carotid arteries, and the process begins again. Heart failure, which is often referred to as congestive heart failure, occurs when the heart is unable to pump an adequate amount of blood to meet the body's metabolic needs, therefore leading to the decreased cardiac output, increased preload, increased afterload, which in turn results in decreased contractility and stroke volume. Heart failure is usually broken down into right-sided heart failure or left-sided heart failure. Right-sided heart failure is a result of ineffective right ventricular contractility, which does not allow the blood to move appropriately out of the right ventricle, causing blood to back up initially in the right atrium, and then in the peripheral circulation system. This creates increased pressure in the peripheral capillary bed, causing the patient to gain weight and have tissue become edematous, as pressure in the capillaries push fluid out of the circulatory system. Whereas left-sided heart failure is a result of ineffective left ventricular contractility. As cardiac output is diminished, blood that is not being pumped to the body backs up in the left atrium and then into the pulmonary circulation system. Pulmonary congestion, dyspnea, and activity intolerance develop as blood backs up into the lungs. According to the CDC, over 5 million Americans have heart failure. 1 in 9 deaths in 2009 included heart failure as a contributing cause, and almost half of the people with heart failure will die within 5 years of their diagnosis. The American Heart Association reported that the annual incident rate of heart failure in Caucasians is approximately 6 per 1,000 individuals, while in the African American population is 9.1 per 1,000. While statistically African Americans have the highest rate of heart failure incidence, the Hispanic population is a close second. Hispanics are the fastest growing population, with an expected rise from 14% of the population in the year 2005 to 29% in 2050. This population segment will be increasingly affected by heart failure and requires increased attention for research and education going forward. Known causes of CHF include coronary artery disease, uncontrolled hypertension, past medical history of a heart attack, congenital heart disease, and the presence of infection. For a physician to determine the diagnosis of congestive heart failure, a history and physical must be conducted. That will also include the ordering of chest x-rays, arterial blood gases, echocardiograms, EKGs, as well as certain labs including BNP. BNP, or brain natriuretic peptide, is a lab test which identifies hormones which are released due to overstretching of the heart. An elevated BNP signifies deteriorating function of the heart muscle. The severity of CHF is determined using the New York Heart Association classification of heart failure. In Class 1, there are no limitations in your daily activities. Class 2 exhibits slight limitations to normal physical activity. Class 3 has marked limitations with less than ordinary activity. And Class 4 symptoms may be present at rest and increased with any activity. Common medication interventions include ACE inhibitors, diuretics, inotropics, beta blockers, and calcium channel blockers. Surgical interventions may include biventricular pacemaker placement, intra-aortic balloon pumps, as well as heart transplant. When considering pathophysiological changes in heart failure, it is common to consider cardiovascular and respiratory systems primarily. Let's first review the cardiovascular system. Having a pre-existing abnormal heart rate, such as AFib, will increase the likelihood of heart failure long term, whereas heart failure itself can initiate an altered heart rhythm related to the heart attempting to compensate for poor perfusion. Tachycardia and low blood pressure are often present in CHF patients. Stroke volume, or the amount of blood ejected from the heart with each contraction, is decreased. Cardiac output, the amount of blood that the heart pumps in 1 minute, is also decreased. This amount is determined by stroke volume multiplied by heart rate. Ejection fraction is also decreased. It is calculated by comparing stroke volume divided by the amount of blood remaining in the left ventricle after contraction. Preload, or the volume entering the heart, and afterload, the pressure the left ventricle must exert to get the blood out of the heart and into the aorta, are both increased. Contractility, the strength of each contraction, is decreased. In considering the creation of a care plan for cardiovascular changes in a CHF patient, this is a good example. Decreased cardiac output related to altered heart rate as evidenced by tachycardia. Respiratory symptoms may include pulmonary congestion, altered breath sounds such as rhonchi or crackles, a wet cough, shortness of breath, dyspnea, orthopnea, and diminished activity tolerance. Pulmonary congestion is caused by left-sided heart failure and therefore blood backup in the lungs. Respiratory function may be diminished with activity or at rest related to the severity. Consider the New York Heart Association classes previously reviewed. Dyspnea occurs due to pulmonary venous congestion, causing pressure to the bronchial and alveolar walls, which affect the exchange between carbon dioxide and oxygen. Orthopnea is caused by increased fluid retention in the abdomen and lower extremities being redistributed to the lungs when the patient is lying down. Alveola, which become fluid-filled, are unable to adequately allow for gas exchange, and the patient may suffer from hypoxia, requiring supplemental oxygen. Care plan options may include impaired gas exchange related to decreased oxygenation, as evidenced by increased respiration rate, moist productive cough, confusion, and pulse oximetry of 80% on room air. Or Impaired activity tolerance related to shortness of breath, as evidenced by increased fatigue, breathlessness, and increased respiration rate. Decreased cardiac output can activate the renin-angiotensin-aldosterone system, causing retention of sodium in water. This system will worsen the presence of hypervolemia in a CHF patient, presenting in peripheral or pulmonary edema. ACE inhibitors, angiotensin receptor blockers, or aldosterone antagonists reduce vasoconstriction and promote the excretion of water and sodium through the kidneys. The sympathetic nervous system, which also induces vasoconstriction and elevates heart rate, may be better managed with beta blockers by inhibiting the sympathetic nervous system. Diuretics are commonly used in the management of fluid retention, and while diuretics may be effective in reducing fluid volume, there needs to be monitoring to avoid dehydration. Patients with decreased ambulatory function may have a reduced quality of life related to diuretic use, causing incontinence or social isolation for fear of needing to urinate while out of the home. Possible care plan options may include fluid volume overload, as evidenced by bilateral lower extremity edema, crackles, and anxiety. Electrolyte imbalance related to fluid shifts, as evidenced by edema. Altered urinary elimination related to increased diuretic regimen. Erectile dysfunction, or ED, is often an early sign of cardiovascular disease in the absence of other symptoms. Many men with heart failure have ED, and it is to be expected related to the same underlying pathophysiology. In a sample of men diagnosed with heart failure, the prevalence of ED was found to be 90%. Further, medications typically used to treat heart failure, such as thiazide diuretics, aldosterone, and beta-blocking agents, exacerbate ED. It should be considered that decreased intimacy and closeness may result in unsuccessful relationships, and therefore may indirectly affect adherence to treatment plans for heart failure. Thyroid hormones can impair cardiac function and in turn cause heart failure in some patients. Common cardiovascular side effects of hyperthyroidism are tachycardia and hypertension, whereas hypothyroidism is associated with bradycardia and hypotension. Alterations in cardiac perfusion can damage the heart muscle, diminishing optimal pumping abilities. A study of over 3,000 participants demonstrated that patients with subclinical hypothyroidism have an increased risk of heart failure. Care plans related to the reproductive system could include sexual dysfunction related to decreased perfusion and activity intolerance. For the endocrine system, endocrine dysfunction related to hypothyroidism as evidenced by bradycardia and hypotension. Malnutrition is often associated with CHF and can occur related to lifestyle, medication, and symptom changes. Sodium restrictions, which are implemented as part of a healthier diet plan, can alter the taste of commonly enjoyed meals. Diuretics reduce saliva production, which can also alter taste and make eating uncomfortable. Medications can cause irritation to the GI system, causing diarrhea, constipation, and nausea symptoms. As CHF progresses, breathlessness occurs with less activity, and therefore cooking meals may be too difficult, as is the process of eating. CHF patients have a risk for malnutrition related to dyspnea and exertion with meal preparation. Albumin and muscular sarcopenia are important markers of protein status because they can predict mortality in CHF patients. Interestingly, skeletal muscle wasting was found in 68% of CHF patients. It is clinically unclear why visceral and muscular proteins break down. However, it is hypothesized the catabolic effects of inflammatory cytokines and neuroendocrine hormones initiate this response. Endothelial cells, which line the interior surface of blood and lymphatic vessels, affecting relaxation and constriction of vessels, can be damaged. Endothelial dysfunction is the inability of the vessel to dilate in response to physiological stimuli, for example, increases in blood flow, and further has been known as a pathophysiological mechanism in the progression of heart failure. A care plan to consider: risk for muscle wasting as evidenced by decreased albumin levels and decreased physical activity. depression, anxiety, and social isolation. The prevalence of depression in heart failure patients has been greater than that of the general population. Depression can lead to increased mortality. 4 pathological patterns that occur in depressed patients parallel the pathogenesis of heart failure, which are neurohormonal activation, hypercoagulability, autonomic neurocardiac dysfunction, and cytokine release. Anxiety has not been as widely researched as depression in heart failure. However, it is a side effect often initiated by respiratory changes such as dyspnea. The sensation of the inability to breathe triggers anxiety symptoms, including increased respiration rate, heart rate, and blood pressure. Social isolation has been found in heart failure patients. Managing medications, altered diet plans, and decreased activity tolerance can limit patients from participating in activities outside the home. Depression and anxiety can also exacerbate this isolation. An appropriate care plan would be mood alteration related to decreased physical ability as evidenced by social isolation, depressive features, and anxiety. In natural aging, the skin undergoes changes, including decreased sensations of pain, vibration, temperature, and pressure. In CHF, these changes may be exacerbated, related to decreased blood flow to receptors or to the brain, which can increase the risk of injury, including falls, decubitus ulcers, burns, and hypothermia. Edema to lower extremities can place an undue stretching to the skin, which may in turn impair skin integrity further. Impaired skin integrity increases the risk of infection. Risk for impaired skin integrity related to bilateral lower extremity edema and activity intolerance is a possible care plan option. Risk for infection related to impaired skin integrity to the sacrum and right lower extremity. Non-modifiable risk factors are those things that we just can't change. They include our race, our age, our gender. Nearly half of all African American adults have some form of cardiovascular disease. Almost 10 per every 1,000 people over the age of 65 years old have a diagnosis of heart failure. And in women, 455,000 new cases are diagnosed each year. To the contrary, modifiable risk factors are things that we can change through lifestyle modification, such as obesity, healthy diets, medication adherence, physical activity, not smoking, and reducing fluids. When creating a care plan for any CHF patient, we should be including knowledge deficit. For example, knowledge deficit related to disease progression, symptom management, and medication adherence as evidenced by rehospitalization within 30 days. In primary rehabilitation services, the focus is on prevention. For heart failure, aside from congenital precursors, maintaining a healthy lifestyle decreases risk factors of cardiovascular disease. Healthy diet, physical activity, and avoiding tobacco products are 3 key preventative measures an individual can do independently. Being aware of family history and genetic predisposition will enable a patient and healthcare provider to assess risks and seek preventative plans. For example, if there is a strong familial history of cardiovascular disease, a physician might recommend the addition of aspirin daily preemptively. In the secondary phase, we're looking at symptom presentation, and the next goal is to have early detection and diagnosis. Education at the primary level from a healthcare provider will enable a patient to respond to clinical changes accordingly. Heart failure may be an acute occurrence that can be reversed with early detection and treatment plan adherence. However, most incidents of heart failure are chronic and progressive. In the tertiary phase, we're looking at symptom management. Rehospitalization of CHF patients has become a major focus of hospitals and reimbursement protocols. Patients must understand their role in assessing, monitoring, and treating hypervolemia. managing salt intake, fluid restrictions, monitoring weight, physical activity is tolerated, taking medications correctly, and recognizing when to notify their healthcare provider are the responsibility of heart failure patients and their caregivers. Telehealth, or remote home monitoring for patients, can facilitate the early identification of disease exacerbation, particularly for patients with heart failure. Telehealth is reducing avoidable rehospitalizations and ER visits. For example, a patient may be instructed to record and report daily weights, heart rate, and pulse oximetry readings. If there are noted variances from previous entries, a nurse would contact the patient, discuss possible interventions, or provide a home visit. Bundled payments through accountable care organizations, or ACOs, are expanding with the focus to improve patient outcomes while concurrently controlling costs, which is the trend for telehealth, and it will continue to gain momentum. Introduction of palliative care for patients with chronic disease processes is crucial, as it is for other progressive diseases such as cancer. Palliative care impacts symptom relief, patient function, and quality of life. Unfortunately, palliative care is often only associated with dying and ending aggressive treatment. Heart failure is categorized by recurrent acute exacerbations, and the availability of modern therapies, which quickly improve highly visible and distressing symptoms like shortness of breath, blur the identification of a terminal phase. Therefore, referrals to palliative care programs may be deferred when they are in fact appropriate. The advanced practice nurse has the ability to enhance care for older CHF patients by facilitating communication through interdisciplinary collaboration, appropriate goal setting, education for the patient and their family about disease processes, self-care, and advanced directive planning. The role of the nurse in managing CHF patients. Our goals are to decrease rehospitalization rates, have excellent clinical assessment skills, implement facility care pathways, collaborate with the interdisciplinary team, advocate for our patients, and provide patient-centered education. The Interventions to Reduce Acute Care Transfer Program, also known as INTERACT, provided a study of 30 nursing homes in 3 states, gave them training, tools, and resources to promote early recognition of changes in resident status. They examined hospital transfers in this study, which were identified as unavoidable by the nursing staff, most of which were residents 70 and older who had been in the facility less than 30 days and had a change in symptoms and signs, the majority of which were for cardiovascular-related diagnosis. However, upon further assessment, they were found to be avoidable transfers. Nurses must have excellent collaboration skills with their CNAs, physicians and nurse practitioners, therapy department, social services, and dietitian in efforts to reduce avoidable hospitalizations. Clinical assessment skills, knowledge of care pathways, understanding clinical interventions available at the SNF, and advocating for the patient is necessary to implement the most effective treatment plan. Nurses play a pivotal role in providing education which is patient-centered. Education must be tailored to meet the needs of the patient and their family. Identify and consider their cultural influences and areas of weakness related to hospitalization history. Nurses provide 24/7 care at a SNF and will observe the subtle and drastic changes in patient status. Concise documentation and patient report is paramount for continuity. Following these CHF protocols, earlier identification and management of changes in clinical status, utilizing care pathways, earlier discussion about advanced directives, and contacting physicians and nurse practitioners timely will reduce the likelihood of undue rehospitalizations and therefore promote a better care experience for your CHF patients and their families. In conclusion, you should have attained the information necessary to meet the objectives set forth at the beginning of the presentation. You should be able to identify pathological changes, more so than just cardiovascular and respiratory in CHF patients. You should be able to identify non-modifiable as well as modifiable pathological factors and use that in your education to patients and families. You can identify primary, secondary, and tertiary rehabilitation services. You have examples of care plan options to implement. You're aware of the role of technology as far as telehealth. You can identify the importance of palliative care appropriateness and timely referrals, and to have appreciation for the nurse's role in patient care. Thank you for your time.